Welcome to the Radiology Economics and Policy Learning Electronic Toolkit, REPLETE. This program was made possible through a GE Healthcare RSNA Education Scholar Grant from the RSNA Research and Education Foundation. I'm Rich Duzek from Emory University, and this session is entitled Coding Systems, CPT, Current Procedural Terminology. This module is targeted to Level 1 of the Diagnostic Radiology Milestones Project of the Accreditation Council for Graduate Medical Education and the American Board of Radiology. Milestones levels differ for the various ACGME-approved radiology training programs, and so if you are in a program other than diagnostic radiology, such as interventional radiology or nuclear medicine, please reference the REPLETE resource webpage for mapping this module to the correct level for your individual program. The learning objectives for this module are as follows: to describe the history and role of the CPT coding system, to outline the steps and criteria necessary to create new and to change old CPT codes, and to explain how radiology professional societies influence the CPT process to ensure appropriate code availability for you and your patients. Here are some additional resources listed alphabetically by author for those who would like to learn more about the topics in this module. In earlier modules, I introduced you to some of the components of the physician payment chain, things that need to happen behind the scenes after you render a service for you to get paid for your work. I introduced you in particular to correct coding as an important link in that chain. In this module, we'll focus on CPT coding. In future modules, we'll focus on ICD coding and get into the weeds more with things like edits and modifiers. One of the messages that hopefully you've grasped by now is that without the right codes, you don't have a claim. The 1500 form, illustrated in paper here, but used in its electronic version by almost all of our practices, requires that everything we do gets distilled down into codes. Codes to identify when a service was performed, how it was performed, and who performed it. And of course, codes to indicate what was done, that's CPT, and why it was done, that's ICD. CPT stands for Current Procedural Terminology. It's a code set maintained and licensed by the American Medical Association ever since 1966. The code set consists of descriptive terms and identifying codes that are used to identify medical services and procedures furnished by physicians and other healthcare professionals. Under the Health Insurance Portability and Accountability Act of 1996, that's HIPAA, it was formally adopted as the nation's preferred procedural coding system. CPT codes are the highest level codes, that's level 1, under HCPCS, the Healthcare Common Procedure Coding System. They describe services and procedures furnished by physicians and other healthcare professionals. But physicians and other healthcare professionals need to report things to payers that aren't services and aren't procedures. That's where Level 2 HCPCS codes come in. Level 2 HCPCS codes are part of a standardized coding system, primarily used to identify products, supplies, and services that are not included in CPT. Examples of these are ambulance services, durable medical equipment, devices, and injectables. Because Medicare and other insurers cover a variety of services, supplies, and equipment that are not described in CPT, Level 2 HCPCS codes were established for submitting claims for these services. These are assigned by the Centers for Medicare and Medicaid Services, not the CPT editorial panel, and that process is beyond the scope of today's module. Throughout REPLETE, we'll be focusing largely on how physicians and their practices report and bill services and how they get paid for them. We'll spend some time talking separately about how hospitals get paid for their services. Remember that we said that CPT codes are used to report services and procedures that are performed by physicians and other healthcare professionals. So, a surgeon performing an appendectomy will report her work using a CPT code. But the hospital incurs services and expenses in providing that service as well, and will frequently report its related bundle of services using an ICD Procedure Classification System code. That's PCS, which stands for Procedure Classification System, and these are functionally used as CPT codes for many hospitals. We'll talk about this part of ICD briefly in the next module, but for all intents and purposes, I'd encourage you to think about ICD-CM, the clinical modification. That's signs, symptoms, and diagnoses, whenever you think about ICD in the context of your own radiology practice. Now, back to CPT. We just said that there are levels of HCPCS codes, but within CPT, there are 3 categories of codes. Category 2 codes describe quality metrics. These are being phased out of the CPT process and are something we won't spend much time on. We'll focus instead on Category 1 and Category 3 codes in these modules. Both are used to report, again, procedures and services rendered by physicians and other qualified healthcare providers. Category 1 codes are reserved for services that have been demonstrated to be effective as well as widely performed. The burden for getting a Category 1 code, as we'll talk about in a bit, is high. Category 3 codes are intended for emerging and investigational services. The threshold to get a Category 3 code is much lower. Some more about the 2 types of CPT codes. Category 1 codes. Some people call these real CPT codes, although both Category 1 and Category 3 codes are real codes. These are almost always valued by the American Medical Association's RBRVS Update Committee, the RUC, and subsequently by the Centers for Medicare and Medicaid Services, CMS. We'll talk about valuation separately down the road. Category 1 codes are typically covered by payers, but again, the burden for approval for one of these codes is rather high. Category 3 codes are sometimes called T codes by some providers because they end in the letter T, as I'll show you in a moment. Sometimes they're referred to as investigational codes. Because these never go to the RUC, because these never get valued by CMS, they're priced at the individual carrier level. So each of these needs to be valued individually by different payers, and they're less likely to be covered by those payers. That's all because it's much easier to get a Category 3 code than a Category 1 code. CPT codes are identifiable as 5-digit codes. Category 3 codes, as I already indicated, are easily identified as alphanumerics that end in the letter T. Category 1 codes are entirely numeric, at least until we run out of 5-digit numbers, which may not be that far down the road. And these are very specific. So for example, if you place a tunneled hemodialysis catheter, to bill for that, you'll use CPT code 36558. If you place a tunneled central venous access port, you'll use a different code, 36561. If you perform a lumbar vertebroplasty, 22511. If you perform a lumbar kyphoplasty, 22514. And back to diagnostic radiology, which is in the 70,000 series of the book. A 1-view chest, 71010. A 2-view chest, 71020. Again, the point is not to memorize these codes, but to recognize that they are very specific and procedure dependent. So how do you get a code? Well, first of all, can you get a code? And you can. Anyone can apply. But even though you can apply individually, very few people do. It's a lot of work and requires a good bit of familiarity with a complicated process. So most applications for CPT codes come from physician specialty societies or corporations. Proposals to get or change a CPT code must be submitted in accordance with a variety of administrative requirements, and they're going to need to meet a variety of stated criteria. We'll talk about those criteria shortly, but the American Medical Association CPT staff will get first crack at reviewing your proposal in light of those criteria. Assuming that you pass those administrative hurdles, your proposal will be disseminated to the entirety of the CPT Advisory Committee. This is a long process. Proposals for CPT codes are rigorously vetted over a process that sometimes takes several years. Typically, collaborative proposals from multiple physician societies fare best. That's because CPT is supposed to be agnostic to specialty, and the codes need to work for every specialty providing a service. Think about inferior vena cava filters, for example, which are commonly performed by both radiologists and surgeons, and increasingly cardiologists. They all need to use the same code, and so this has to be vetted in a multi-specialty manner to make sure that the code proposal works for everybody. Ultimately, all 100-plus members of the AMA CPT Advisory Committee will be encouraged to review and comment on all code change proposals, ideally to make those change proposals stronger and better. Now, those comments all become part of the packet for when a CPT code change proposal is presented and discussed at a meeting of the CPT editorial panel. The panel, as it's referred to, meets 3 times a year and is the final arbitrator of the CPT code set. Once your proposal goes live on the editorial panel's agenda, there's no pulling back. So an applicant, whether an individual or a professional society or a corporation, needs to carefully consider all scenarios when they move forward trying to get a code change for either an old one or a new one, because sometimes things happen that they don't anticipate or that they don't want. Sometimes your proposal, after it goes to the editorial panel, will get rejected, and now you're back at square one. As a general rule, though, you'll get some good feedback and rationale from the editorial panel as to why that happened, and you can use that to resubmit should you choose to do so, hoping for a better outcome next time. Even if you get your code approved, the code doesn't go live right away. New Category 1 codes go into effect only once a year, and with the last editorial panel meeting of each year in either September or October, it can take as long as 15 or 16 months until you can use that new code. A lot happens during that time. There's usually some administrative cleanup that has to happen, which gets done by the CPT editorial panel's executive committee or the AMA staff, or sometimes both. Sometimes those are done in conjunction with the applicant, sometimes on their own. That's all necessary to get a code ready to go to the next step, which is valuation by the RBRVS Update Committee. The RBRVS Update Committee, something we'll talk about in more detail in another module, also meets 3 times a year. It's usually a few months after each editorial panel meeting. Through a very involved process, the RUC assigns relative value units to every Category 1 code, and those RVUs are then used by CMS, the Centers for Medicare and Medicaid Services, to assign a fee based upon an established formula. Now, this is not a fly-by-night process. It's actually a pretty complicated and rigorous process, but it is open and transparent. That means anyone can attend a CPT editorial panel meeting, and you'll get to see, in action, all these rules coming into play. And like any rule-based process, is if you don't follow the rules, you won't get a code. So let's talk about a couple of them. Some of these are pretty common sense. If you want to submit an application, it needs to be complete. And if you want your proposal to be discussed at a meeting, you have to meet the deadlines for that meeting. Everybody does better if they cooperate, cooperating with requests from CPT staff, from advisors, from the editorial panel, because collaboration is how this process works. And obviously, to do that, people need to cooperate and participate and provide information to make things work as well as possible. But you need to make sure you play fair and square. Trying to bribe, lobby, or otherwise improperly influence a CPT advisor, or worse yet, a voting editorial panel member, may get you completely excluded from the process. So this is a process where you really want to rely on an experienced team and not make rookie mistakes. Fortunately, our professional societies in radiology are about as experienced as you can get. There are a lot of criteria you need to meet to successfully pitch a code to the editorial panel. These criteria apply whether you're shooting for a Category 1 code or a Category 3 code. So let's highlight a few. Your proposed descriptor needs to be unique and well-defined and clearly identified and distinguished from other services. If physicians don't know what your code proposal means, or coders don't know how to use that code, then it probably won't get approved. Codes need to work broadly for how services are typically performed. If you're providing a niche service that no one else does in a manner different from your colleagues, you probably won't get your own personal code. Let's spend a moment now talking about Category 3 codes. Remember, these are used to report emerging or investigational services, so the bar is pretty low. But there is a bar. The services need to be currently or recently performed in humans. So if it's something that you're thinking about starting a year or two down the road, it's premature to apply for a Category 3 code. And if you're performing the procedure, say in an animal model, but not yet in humans, that's not good enough. You'll additionally need at least some testimony that the service is being performed by specialty society support or peer-reviewed literature, or at least an IRB somewhere saying that they have a protocol in place. For Category 1 codes, that bar goes up quite a bit. First of all, if the service involves a device or drug, it needs to be FDA cleared or approved. There needs to be ample peer-reviewed literature to support the efficacy of the procedure. In general, you'll need at least 5 peer-reviewed articles, with the best having at least level 2 or level 3 evidence. Those literature requirements have been updated a couple times in the last few years and are being revised yet once again as we speak. And remember, it's current procedural terminology, not niche or theoretical procedural terminology. So the service needs to be performed by many physicians or qualified healthcare providers across the United States. If it's just being performed at 1 or 2, or maybe even just a handful of centers, then it's probably not ready for a Category 1 code. And it needs to be performed with sufficient frequency relative to its intended use. So, if you have a new procedure for treating appendicitis, say, which is a pretty common disease, you'll need to show that the procedure is done or going to be done a lot. If it's a procedure for a super rare congenital cyanotic heart disease that only involves a couple dozen infants a year, a handful of cases each year may turn out to be just enough. Ultimately, after you get a Category 1 code, it goes off to the RBRVS Update Committee for valuation in anticipation of inclusion in the Medicare Physician Fee Schedule. Now, if you get a Category 3 code, the code stops at CPT, and you're going to have to work with local carriers who will have to determine each individually their own prices if they cover that procedure at all. And frequently they won't. Now, remember the CPT imperative. It's important for a couple reasons. If your coders can't apply a code to your report, either because they can't figure out what you were trying to say, or because there is no code for that service yet, they're instructed to use an unlisted procedure code. UPCs, or unlisted procedure codes, typically require paper claims, which slow down the electronic payment chain quite a bit. And claims with unlisted procedure codes are much more likely to be rejected than ones with approved codes. This is important at both the big picture policy level, but also at the individual practice revenue cycle level. First, from a higher and broader policy level, if you're a researcher or a vendor, no one is going to adopt your service or procedure if they don't get paid for it. Think about how doctors work in real-life clinical practice. So you need to be thinking ahead to that step to really translate your new technology into widespread clinical use. Remember, this is a complex and nuanced process, and you don't want to go it alone. That's why our professional societies are so important in guiding researchers and industry through this process. Let me share with you a bit the story of CT colonography. This was first described somewhere around 1994, and from 1994 until about 2004, this was reported using 3 CPT codes: a CT scan of the abdomen, a CT scan of the pelvis, and a then 3D reconstruction code. Medicare and Blue Cross Blue Shield Association of America decided somewhere before 2004, though, that this bundle was being performed commonly together, and both put forth code change proposals to categorize this in Category 3 with its own distinct code. So a Category 3 Investigational Emerging Technology CPT code came about in 2004, late that year, and stayed in effect through 2009. Now, between 2004 and 2009, the literature evolved. It now met the Category 1 literature burden. More folks were doing it, so it met the many provider threshold. And it was being done with increasing frequency, so it met that volume in relationship to clinical indication threshold. As a result, codes for CT colonography went from Category 3 to Category 1 status in 2010, which is where they currently reside. But that doesn't mean it automatically got paid. Remember medical necessity. As a general rule, unless there is specific legislation or regulation in place, screening services aren't covered by Medicare and private payers. But with the United States Preventive Services Task Force recognition of CTC, things began to change. That's because under the Affordable Care Act, better known as Obamacare, USPS task force recommendations typically translate into mandatory payer coverage. Diagnostic indications are another matter. There, the issue is proving to payers, one by one, because it's a slow and laborious process, that a service is clinically effective. The radiology community, led by the American College of Radiology, has made a lot of headway, and now this service is covered by nearly all payers in at least some circumstances, all across the country. Here's some work my colleague Kelly Cox from Emory University recently published in Abdominal Radiology, looking at Medicare denial rates for diagnostic CT colonography. For the first full year of Category 3 codes, that's 2005, almost 3/4 of cases were denied payment by Medicare carriers. But with a lot of ongoing coordinated advocacy, educating payers about the rapidly evolving peer-reviewed literature, denial rates dropped to about 1 in 3 by 2010, when Category 1 codes came out. And they've been pretty stable ever since. So it's probably more the literature support, rather than the code status alone, that impacts payer coverage of new services. I've mentioned the role of organized radiology many times, and it's critically important in this discussion. The ACR and a variety of other professional societies have a huge team of tireless volunteers that attend each and every one of these meetings and work to get new codes on your behalf. Radiologists participate in this process at several levels. Almost all professional societies, and radiology has a number, have seats on the CPT Advisory Committee. Of the advisors who really work hard and have great talent, and sometimes some luck too, some of those will get their own seat on the 17-member editorial panel that's appointed by the American Medical Association Board of Trustees, and actually be the decision makers, the folks who get to vote on these codes. And of that 17-member editorial panel, the ones that have the most influential voices will be the ones who will be elected by their own peers on the editorial panel to its 5-member executive committee. Now, most radiology activities are led by the American College of Radiology. If you look at the 2017 CPT book, you'll see Dr. Dan Pikus from Mallinckrodt Institute of Radiology listed as the ACR CPT advisor. He has since moved on to the editorial panel and has been replaced by Dr. Mark Olson from Fresno, California. Radiologists are leading these activities. Many radiology societies collaboratively participate in initiatives to ensure appropriate codes for all of the houses of radiology and together put together these code change proposals. How do people get on the CPT Advisory Committee? Well, professional societies get a seat on the CPT Advisory Committee if they have standing at the AMA's House of Delegates. That means that a certain threshold of those professional societies' members need to be members of the AMA. And so, AMA membership, regardless of what you think of the organization, is very important for us to have a seat at the table. If you look at the 2017 CPT book, you'll see these individuals listed as representing various diagnostic radiology, interventional radiology, nuclear medicine, and radiation oncology societies. These individuals all work together in a coordinated manner to support the needs of the entire House of Radiology. Remember again, the American Medical Association Board of Trustees appoints the editorial panel. There are no specialty-specific seats. Radiologists are not guaranteed a seat at this table, but radiologists have served on the panel in all but a few of its 50-plus years of existence. If you look at the 2017 book, you'll see 2 radiologists listed there. I just went off the editorial panel, term limited. Dr. Kathy Kroll, an interventional radiologist from Indianapolis, continues to serve on the editorial panel. Both of us actually served on its executive committee. So we've had 2 of 5 members of the executive committee represented by radiologists. Dr. Dan Pikus now is on the editorial panel, so we're back again to 2 radiologists on the editorial panel. Now, that's the big picture stuff. Let's pivot back to your individual practice. And again, let's talk about the accuracy imperative. Why is it important here? Because correct coding is going to hinge on your appropriate documentation. And we're in an environment in which fraud and abuse scrutiny is high. So you've got to get it right so you don't leave money on the table, but you don't have people coming after you because you asked for too much money. And again, CPT codes are very specific here. So I've showed you previously the example of a 1-view chest radiograph and a PICC line in an older child or adult. They're going to be different codes, though, from a 2-view chest radiograph or a PICC in a younger child. So you're going to need to make sure that you capture this information in detail so that it can be translated to your coders. And again, your coders are going to be your friends, and your templates are going to be the way to interact with those friends. There's a lot of rules that come into play here. And that's why structured reporting is going to be the most effective way to ensure that your hard work is accurately and efficiently translated into the ICD and CPT codes that are necessary to get you paid. We can't make each and every radiologist an expert in this space, but we can, through practice initiatives that we'll talk about throughout the remainder of Replete, create systems that allow all of our radiologists to be as successful as possible. So in summary, the process of obtaining a new CPT code or modifying an existing one is a complicated, rigorous, time-consuming, and resource-intensive one. But since CPT codes are an essential first step in physician reimbursement, such efforts are going to be critically important. Your professional societies work tirelessly to advocate for our specialty. I would encourage you to continue to support your many professional societies throughout your careers as dues-paying members and hopefully as volunteers as well. To ensure appropriate credit for this module, please make sure that you complete the accompanying online quiz from the RSNA's e-learning platform. More information on the REPLETE initiative and additional resources are available on the RSNA's website. I'm Rich Duzak from Emory University, and I look forward to helping you continue along your economics and health policy milestones journey. Again, thank you for participating in REPLETE.